Good morning, and thanks for joining us for Winship Grand Rounds. If you're an Emory University or healthcare employee and like to receive credit CME-wise for attending today, the login information can be found in the chat feature at the bottom of the screen. If you have any issues with the webinar or the CME login, please send Julie Hawkins an email or drop a note via the chat feature. This morning for Grand Rounds, we're pleased to welcome Dr. Manali Bhave. Dr. Bhave is an assistant professor in the Department of Hematology and Medical Oncology. She's board certified in medical oncology and internal medicine and specializes in breast oncology. She earned her medical degree from Northwestern in Chicago and completed residency in internal medicine and women's health also at Northwestern. She then completed fellowship in medical oncology and hematology at Michigan in Ann Arbor, Go Blue, where she served as chief fellow in her final year. She then joined the Glenn Family Breast Center here at Winship in 2018, and prior to that, she was a clinical instructor at Northwestern in Chicago. Dr. Bhave certainly has a special interest in developing new strategies and treatments for women with breast cancer. She's an active member of that group, as well as our phase 1 group, and collaborates with other Winship members across clinical trial spaces. Her goal is to provide compassionate, personalized, state-of-the-art care for patients through the use of standard of care therapies and investigational agents. Her research focuses in the development of novel therapies, including immunotherapy and multimodality strategies for breast cancer treatments. She's also got an interest in fertility care during breast cancer management and improving quality of life for patients. She serves as a principal investigator for many ongoing and upcoming trials within the breast cancer working group and the phase 1 group, and she's certainly been a great addition to both. Welcome, Dr. Bhave, and we're excited to hear what you have to tell us about triple-negative breast cancer.
Thank you so much, Donald. And thank you for the opportunity to present at Winship Cancer Center Grand Rounds today. The title of my talk is The Evolving Landscape for the Management of Triple-Negative Breast Cancer. The talk I'm giving is actually very timely since it's my favorite time of the year, October, and Breast Cancer Awareness Month. And I'm excited to share updates in the treatment of patients with triple-negative early stage and metastatic breast cancer, along with several of my own research projects in this space since I joined Emory in 2018. I'll start my presentation today with triple-negative breast cancer epidemiology and biology, followed by updates in the approved immunotherapy and targeted therapy options for the treatment of metastatic triple-negative breast cancer. I'll then discuss the new approval of immunotherapy in early stage triple-negative breast cancer, and end with a discussion on ctDNA monitoring as a sensitive method to predict early relapse in early stage triple-negative breast cancer and potentially guide adjuvant treatment strategies. Triple-negative breast cancer is defined by the lack of estrogen, progesterone, and HER2 receptors and accounts for significant mortality and morbidity in breast cancer care. It accounts for about 15 to 20% of invasive breast cancers and unfortunately affects young women and African-American women disproportionately. Patients with triple-negative breast cancer are more likely to present with advanced stage disease due to the aggressive underlying biology, often involving visceral organs such as the brain and liver. Until recently, chemotherapy was a standard of care treatment for triple-negative breast cancer, given the lack of targets. And while we have made advances in utilizing immunotherapy and other targeted agents in triple-negative breast cancer, the survival still remains poor, with a median overall survival in metastatic triple-negative breast cancer of 15 to 18 months and 5-year overall survival of approximately 12%. Immunotherapy has actually prolonged survival in other solid tumors and is now a promising treatment strategy for triple-negative breast cancer. In this slide, I want to actually highlight the rationale behind the use and efficacy of immunotherapy in triple-negative breast cancer. Several characteristics make triple-negative breast cancer more likely to respond to immunotherapy compared to other subtypes of breast cancer. First, on the left, we'll see that triple-negative breast cancers have more TILs, which actually correlates to better responses to immune checkpoint inhibition in other solid tumors, and we know is actually associated with an improved prognosis in early stage triple-negative breast cancer, possibly due to actually enhanced sensitivity to anti-cancer therapies, including chemotherapy. In the center graph, we'll see that triple-negative breast cancers express higher levels of PD-L1 expression, which provides a direct target then for immune checkpoint blockade. And on the right, we'll see that triple negative breast cancers have a greater number of non-synonymous mutations or higher mutational burden, which gives rise to tumor-specific neoantigens that activate neoantigen-specific T cells to mount an anti-tumor response. These responses are then strengthened by the use of immune checkpoint inhibitors. Let's start with a look at immunotherapy and other targeted agents, including antibody drug conjugates and PARP inhibitors for the treatment of metastatic triple-negative breast cancer. PD-1 and PD-L1 inhibitors were first studied as actual single agents in metastatic breast cancer, as summarized in this slide, and showed modest activity across all antibodies targeting the PD-1 axis, including Pembrolizumab, Avelumab, and Atezolizumab. As you can see in the slide, the greatest benefit was seen in triple-negative breast cancer compared to other breast cancer subtypes, particularly actually within a subtype of triple-negative breast cancer that were positive for PD-L1, with objective responses varying from 5 to 24% and a median duration of response somewhere between 6 and 8 months, per Keynote-086 using Pembrolizumab and the Javelin trial using Avelumab. The median duration of response is not listed for all trials because it's still actually ongoing for the trials not listed. Greater benefit was actually seen with immunotherapy in combination with chemotherapy as opposed to single agent immunotherapy for the treatment of metastatic triple-negative breast cancer. And here I've highlighted IMpassion130, which is a double-blind placebo-controlled phase 3 trial of atezolizumab plus nab-paclitaxel versus placebo and nab-paclitaxel for patients with treatment-naive metastatic triple-negative breast cancer. Patients were randomized 1-to-1 to each arm of the trial and continued on therapy until progression of disease per RECIST or unacceptable toxicity. Of note, patients were stratified by prior taxane use, liver metastases, and PD-L1 expression, which was defined by at least 1% on tumor infiltrating immune cells per the Ventana SP142 assay. Co-primary endpoints were progression-free survival and overall survival in both the intention to treat population, regardless of PD-L1, and the PD-L1 positive population, though not statistically powered in the PD-L1 population. Secondary endpoints are listed. A quick look at the patient characteristics are really notable that the majority of patients had received chemotherapy in the early stage setting, with a little over 50% receiving an anthracycline and taxane-based neoadjuvant or adjuvant chemotherapy. Of note, IMpassion130 excluded patients with early relapse who developed recurrent metastatic disease within 12 months of trial enrollment, which unfortunately excluded a very high-risk population with poor outcomes. It's also important to note on the right that PD-L1 positivity rate defined in this trial was approximately 41% per the Ventana assay, which is similar to the rates that were seen in subsequent trials using the same assay. While statistical significance was not actually crossed in the intention to treat population for the co-primary endpoints of PFS or OS, as shown in the Kaplan-Meier curve in the left, there was clinically meaningful benefit seen in overall survival in the PD-L1 subtype population, with an improvement in overall survival of approximately 10 months from 15 to 25 months in those that received atezolizumab. This led to the accelerated FDA approval of atezolizumab plus chemotherapy, nab-paclitaxel, in metastatic triple-negative breast cancers in tumors that express PD-L1, defined again as greater than or equal to 1% per the Ventana SP142 assay. Updated survival data on the right showed a persistently clinically meaningful benefit in overall survival, with a continued median overall survival of 25 months in the atezolizumab chemo arm versus 18 months in the placebo chemo arm. PFS was also improved in the PD-L1 positive subgroup, though just with a modest benefit of approximately 2.5 months, with PFS of 7.5 months with atezo chemo compared to 5 months in those that received chemotherapy alone. In April of 2021, ODAC voted in favor of continued approval of atezolizumab in combination with nab-paclitaxel for the treatment of PD-L1 positive metastatic breast cancer based on the updated survival and safety data. With regards to the safety data, the safety data updates showed that atezolizumab in combination with nab-paclitaxel was safe and tolerable and very consistent with the primary analysis, with the most common AEs being neutropenia, peripheral neuropathy, fatigue, and anemia. There were actually no significant differences in adverse events of special interest, including immune-related adverse events, with the most common immune-related adverse event being hypothyroidism. Given the higher clinical use of actual paclitaxel and wider access to paclitaxel compared to nab-paclitaxel globally, Genentech proposed a study of atezolizumab and paclitaxel for patients with metastatic triple-negative breast cancer. This trial is in Passion 131. In this trial, 651 patients with metastatic treatment-naive triple-negative breast cancer who had completed definitive therapy within at least 12 months prior to randomization were randomized 2-to-1 to receive atezolizumab plus paclitaxel versus placebo plus paclitaxel until disease progression or unacceptable toxicity. Again, patients were stratified by taxane use, PD-L1 expression, liver mets, and interestingly by geographic region, because again, the fact that nab-paclitaxel is not globally used as often. Again, in the study, approximately 44% of patients were PD-L1 positive. The primary endpoints for this trial were progression-free survival, with secondary endpoints including overall survival, overall response rates, PFS by independent review, some patient-reported outcomes, and translational endpoints, including biomarkers to predict response to immunotherapy. In contrast to the survival benefit shown for atezolizumab plus nab-paclitaxel in the previous Impassion 130 trial, atezolizumab plus paclitaxel actually failed to improve outcomes in Impassion 131, which was presented at ESMO in 2020. As we can see on the left with progression-free survival, there was no significant improvement with the addition of atezolizumab to paclitaxel in either the PD-L1 positive population at the top compared to the intent to treat population below. It's 5.7 months. In the PD-L1 population, it was 6 months versus 5.7 months. The combination also did not improve overall survival as depicted in the Kaplan-Meier curves on the right, in either the PD-L1 positive subgroup at the top or the intention to treat population below. These results were highly unexpected, and the potential reasons for actual contrast in benefit compared to Impassion 130 with the use of paclitaxel is really unknown and requires further exploration. In August of 2021, we're all very surprised to hear that Genentech had actually pulled atezolizumab FDA review for metastatic triple-negative breast cancer. The sudden withdrawal was a bit unclear for all of us, though may in part be due to the disappointing Impassion 131 results and the recent approval of Pembrolizumab for the treatment of PD-L1 positive metastatic triple-negative breast cancer. Keynote 355 is a double-blind placebo-controlled randomized phase 3 trial of Pembrolizumab now plus chemotherapy versus placebo plus chemotherapy in patients with treatment-naive metastatic triple-negative breast cancer. In this study, 847 patients were randomized 2-to-1 to receive Pembro plus investigator's choice of 3 chemotherapy backbones, including nab-paclitaxel, paclitaxel, or carboplatin plus gemcitabine. The other arm was placebo plus chemotherapy, with patients followed until disease progression, unacceptable toxicity, or 35 cycles of Pembro or placebo. Interestingly, and of note, early relapses were allowed on this study as long as they had completed curative intent therapy at least 6 months prior to recurrence. Patients were then stratified by chemotherapy backbone, PD-L1 expression, and previous treatment with the same class of chemotherapy. The primary endpoints for this study were progression-free survival and overall survival, separated actually by PD-L1 expression. In this study, it's important to note that PD-L1 expression was per the combined positive score through the DACO 22C3 assay, and were stratified by scores greater than or equal to 10, greater than or equal to 1, or in the intention to treat population. Briefly, patient characteristics are noted in this table and were really similar across both subgroups, both treatment arms, with approximately 75% of patients with CPS scores of greater than or equal to 1, and approximately 36% of patients having CPS scores greater than or equal to 10. The majority of patients received CarboGem as a chemotherapy backbone on this trial, and so did not end up receiving the same class of chemotherapy prior to trial enrollment. Among patients with CPS, a PD-L1 CPS score of at least 10, the median progression-free survival as depicted in the curve on the left was 9.7 months in the pembrolizumab arm versus 5.6 months in the placebo arm, with a hazard ratio of 0.65. The survival difference reached statistical significance. PFS also improved, but less so for patients that had lower CPS scores of at least 1, as shown on the right, with a PFS of 7.6 months with Pembro compared to 5.6 months with placebo. Although the boundary for statistical significance did not reach benefit in Pembro chemo for patients that had CPS scores of 1 or greater, it still showed that the Pembro treatment effect increased with PD-L1 enrichment. Investigators also observed overall response and disease control response benefit for Pembro versus placebo across the PD-L1 CPS groups and in the intention to treat population. However, in the pembrolizumab group, a PD-L1 CPS score of 10 or more resulted in higher overall response rates compared to PD-L1 CPS scores of at least 1, and in those unselected, PD-1 unselected intention to treat population. This was seen regardless of the chemotherapy backbone paired with pembrolizumab or the placebo. Benefit with pembrolizumab on duration of response was again seen across all subgroups, with the greatest benefit in duration of response of 19 months versus 7.3 months in patients that had a higher CPS score of at least 10. Based on this data and the fact that PD-L1 enrichment corresponded to response to pembrolizumab in combination with one of the 3 chemotherapy backbones received accelerated FDA approval in November 2020 for patients with locally recurrent unresectable or metastatic triple-negative breast cancer whose tumors express PD-L1, defined as a CPS score of at least 10 or higher based off of the DACO 22C3 assay. Overall survival data for this is pending. Of note, the adverse events, grade 3 to 5, were actually similar between the two groups, 68% with Pembro and about 66% in the placebo chemo arms, with grade 3 to 4 immune-related adverse events being low at approximately 5%. In summary, pembrolizumab plus chemotherapy is approved in the first line for patients with metastatic triple-negative breast cancer who express PD-L1 based off of the CPS score of at least 10. That median progression-free survival benefit, as mentioned, was about 9.7 months, compared to 5.6 months with chemotherapy alone. And while PFS did improve regardless of the chemotherapy partner in the intention to treat population and across PD-L1 subgroups, though the greatest benefit was again seen in patients that had the CPS scores of at least 10. Currently, pembrolizumab in combination with chemotherapy is the only FDA-approved treatment, only FDA-approved immunotherapy option for the treatment of patients that have PD-L1 positive metastatic triple-negative breast cancer. There have also been significant advances in other targeted therapies for the treatment of metastatic triple-negative breast cancer. This is actually a really nice figure by a review by Vidula et al. In JNCCN that highlights the molecular targets discovered for triple-negative breast cancer. Broadly speaking, the actionable targets can really be divided into 3 categories: targeting genomic mutations in key intracellular signaling pathways, targeting cell surface markers for selective delivery of potent agents, and targeting the immune microenvironment. While we've made significant progress in the fight against metastatic triple-negative breast cancer, novel strategies are really needed to actually prolong the immune response. These could include novel combinations with partner systemic therapies such as PARP inhibitors, AKT inhibitors, antibody drug conjugates, or even other chemotherapy backbones. But also we should be thinking about combining with alternative treatment modalities such as radiotherapy to prime or resensitize the immune response in triple-negative breast cancer. With the recent approvals of immunotherapy in triple-negative breast cancer and the exciting but still modest benefit, I really started thinking about strategies to prolong the immune response with immune checkpoint inhibitors. And one potential strategy of particular interest to me was a combination of radiotherapy as a primer to stimulate the immune response to immunotherapy in triple-negative breast cancer. The rationale behind this is that radiotherapy is already frequently used for palliation in patients with metastatic triple-negative breast cancer and was actually allowed in Impassion 130 and Keynote 355, though not published. RT is a potent immune response modulator, which reported to produce responses in unirradiated tumors when combined with immunotherapy and other subtypes of cancer. This effect is called the abscopal effect, but has not been well studied in triple negative breast cancer. Immunomodulator effects of the combination of radiotherapy and immune checkpoint blockade has also been reported in numerous preclinical and clinical trials that included women with metastatic breast cancer. This included actually a small phase 2 trial by Alice Ho and team at Memorial Sloan Kettering, where they combined radiotherapy plus pembrolizumab as a single agent in patients with metastatic triple negative breast cancer, regardless of PD-L1 expression. In those patients, they received pembrolizumab given 1 to 3 days after the first fraction of palliative radiation and was continued every 3 weeks. Patients also received 3,000 centigrades delivered in 5 daily fractions to at least one site of metastatic disease. And what we see is that there was actually a pretty high overall response rate of approximately 17%, though again in a small population of patients. And at 13 weeks, 3 of 17 women actually achieved a complete response with 100% reduction in tumor volume outside of the field of radiation. Interestingly, all 3 patients had PD-L1 positive tumors. Pembrolizumab and RT on the trial, as mentioned, was safe as well and demonstrated encouraging activity in patients with an otherwise poor prognosis, again, specifically in that PD-L1 positive population. Using this rationale, I actually collaborated with one of my mentors, Dr. Mylan Torres, to develop a phase 2 clinical trial of radiation therapy in combination with immunochemotherapy for the treatment of metastatic PD-L1 positive triple negative breast cancer, in hopes of prolonging the immune response with RT and investigating actually the abscopal effect in triple negative breast cancer, which to date has not been well defined. Patients with metastatic PD-L1 positive triple negative breast cancer with at least 2 sites of disease are eligible for the study and will receive 3 fractions of high dose palliative radiation and 8 grays every other day with the start of pembro plus chemotherapy within 48 hours. This is based on prior studies showing that the greatest benefit with the immune stimulating effects of radiation therapy was when immunotherapy either started shortly after initiation of radiotherapy or concurrently with radiation. The primary endpoints for the trial will be 12-month PFS compared to historic control, with secondary endpoints being objective response rates, progression-free survival, overall survival, and safety. We'll also be monitoring for serial ctDNA as a marker of treatment response and assessing changes within the tumor microenvironment through single-cell mass cytometry and RNA-seq in collaboration with Drs. Kavitha and Madhav Jodhavkar. There have been several revisions to the original study design, including the change in immunotherapy agents based off of the recent approval of pembrolizumab and now with the withdrawal of atezolizumab, as well as refining some of the endpoints for the trial. However, the clinical protocol is now complete. I've also secured partial funding for the trial through the Winship Invest pilot grant, and we'll be sending the trial shortly to PRMC and IRB for review. We hope to open the trial in the spring of 2022 and look forward to seeing the results. Of note, I also collaborated with Dr. Torres on a multi-institutional phase 2 trial to evaluate the efficacy and safety of talazoparib, a PARP inhibitor, plus radiotherapy and atezolizumab in germline BRCA1/2 negative patients with PD-L1 positive metastatic triple negative breast cancer in the 2nd and 3rd line setting to see whether we can resensitize the immune response. Dr. Torres secured funding from Pfizer and Genentech for the trial, and this clinical trial is currently enrolling, with our first patient enrolled in the last couple of weeks. Next, we'll move on to another exciting development in metastatic triple negative breast cancer. And this is a novel antibody drug conjugate, our first actually approved antibody drug conjugate in metastatic triple negative breast cancer called sacituzumab govitecan. Sacituzumab govitecan is an ADC in which SN38, an active metabolite of irinotecan and a topoisomerase I inhibitor, is coupled to the humanized anti-trophoblast cell surface antigen 2, or TROP2, monoclonal antibody. On binding to TROP2, sacituzumab govitecan delivers the payload into the tumor cells, leading to cancer cell death. There also appears to be a bystander effect in which the payload is released from the anti-TROP2 antibody and actually diffuses into neighboring TROP2 negative cells. IMU-13201 was a pivotal phase 1-2 trial of sacituzumab govitecan in patients with metastatic triple-negative breast cancer who had received at least 2 prior lines of chemotherapy, including potentially 1 line of chemotherapy in the early stage setting. Patients must have received prior taxane. Patients continued on sacituzumab govitecan until disease progression or unacceptable toxicity, with endpoints being safety, immunogenicity, TROP2 expression, and response evaluations. In this pivotal phase 1-2 clinical trial, we can see that there was significant benefit in heavily pretreated patients with metastatic triple-negative breast cancer, with an objective response rate of 34%, including some complete responses. The responses also appear to be deep and durable, with a median duration of response of 7.7 months and a progression-free survival of 5.5 months. Overall survival also significantly improved to 13 months. Grade 3 toxicities listed in the slide included neutropenia, diarrhea, and febrile neutropenia, though all well managed. The confirmatory phase 3 randomized clinical trial of sacituzumab govitecan in metastatic triple-negative breast cancer, also called the ASCENT trial, compared sacituzumab govitecan versus standard chemotherapy for patients with pretreated metastatic triple-negative breast cancer, including, again, at least 2 prior lines of chemotherapy. Patients were randomized to receive sacituzumab govitecan on days 1 and 8 versus physician's choice of chemotherapy. The primary endpoint was to look at PFS by independent review committee in patients without brain mets, and secondary endpoints included PFS in the full population, overall survival, objective response rates, duration of response, and safety. Of note, the trial was actually halted early based off of the efficacy seen in the patients enrolled, and was a unanimous decision by the DSMC. The median progression-free survival was 5.6 months with sacituzumab govitecan versus 1.7 months with standard chemotherapy, which was incredibly statistically significant and clinically meaningful. The overall survival in patients treated with sacituzumab also doubled compared to those treated with standard chemotherapy, as noted in the Kaplan-Meier curve and the table above, with a hazard ratio of 0.48. The most common grade 3 events really remained the same as per the phase 1 and 2 trial, including hematologic toxicities, mostly neutropenia, diarrhea, and fatigue. The FDA granted regular approval to sacituzumab in April of 2021 for patients with metastatic triple-negative breast cancer who have had at least 2 lines of prior systemic therapy, with at least 1 line in the metastatic setting, in the early stage setting, and 1 in the metastatic setting. In the interest of time, I wanted to quickly review data on 2 PARP inhibitors recently approved in metastatic triple-negative breast cancer. This OlympiAD study is a phase 3 trial of olaparib, an oral PARP inhibitor, versus physician's choice of chemotherapy in patients with either metastatic hormone receptor positive triple-negative breast cancer with germline BRCA1 or 2, germline BRCA1/2 mutations who have received chemotherapy in the neoadjuvant, adjuvant, or metastatic setting. And if they had received platinum, were still believed to be platinum sensitive. The primary endpoint for the trial was PFS. And as seen on the right, the primary endpoint was met with patients who had received olaparib having approximately 3-month improvement in PFS of 7 months compared to 4.2 months in the chemotherapy arm. OlympiAD also showed an improvement in median overall survival of approximately 8 months, with showing a median overall survival improvement of approximately 8 months, with overall survival being 22 months in patients with olaparib versus 14 months in those with chemotherapy. Olaparib is the first oral PARP inhibitor that was actually approved for metastatic hormone receptor positive and triple-negative breast cancers in women with germline BRCA mutations in January of 2018. Talazoparib, a second PARP inhibitor, was also approved shortly after, based off of the phase 3 BRCA data, although I won't go into that in the interest of time today. Of note, PARP inhibitors have now also transitioned to the early stage setting, with adjuvant olaparib times 1 year demonstrating a significant improvement in 3-year IDFS per a pre-specified interim analysis in the OlympiAD trial in patients that have high risk hormone receptor positive HER2 negative or triple negative invasive breast cancer, and who carry the germline BRCA mutation. I'd now like to switch gears to advances we've made in the treatment of high-risk early-stage triple-negative breast cancer, and we'll start with the recent approval of immunotherapy pembrolizumab in the neoadjuvant setting. So KEYNOTE-522 is a randomized double-blind placebo-controlled phase 3 trial of patients who have at least 2 centimeters of disease within the breast or are node positive. Patients were randomly assigned in a 2-to-1 ratio to receive intensive chemotherapy, including carboplatin plus paclitaxel, followed by anthracycline plus cyclophosphamide, plus either pembrolizumab or placebo. Patients then went for surgery, followed by adjuvant pembro for 9 cycles. Adjuvant Xeloda was actually not allowed on the trial, although it is current standard of care. Baseline characteristics were relatively the same in both cohorts, with approximately 80% of patients being PD-L1 positive, though again, PD-L1 expression was not required for enrollment on the trial. The PAT-CR rates were 65% with pembrolizumab plus chemotherapy versus 51% with placebo plus chemotherapy in the intention to treat population, though it was significantly higher with PAT-CR rates reaching around 69% in the PD-L1 positive population. And they were actually lower in the PD-L1 negative population, as noted in the table to the right. Notably, the greatest benefit was actually seen in patients that had node positive disease, with an absolute benefit of approximately 20% with the addition of pembrolizumab to chemotherapy. The addition of pembro to chemo, followed by pembro in the adjuvant setting, also showed a favorable trend in event-free survival, with a hazard ratio of 0.63 and approximately a 6% difference at 18 months in event-free survival. Additional follow-up to 36 months showed a persistent improvement in event-free survival favoring pembro chemo at approximately 7.7%. Across treatment arms, the most common grade 3 adverse events were similar, being febrile neutropenia, anemia, and pyrexia. The only adverse events of interest possibly related to immunotherapy, grade 3 or higher, occurred in about 10 or more patients receiving pembrolizumab and included mostly skin reactions, infusion reactions, and adrenal insufficiency. Based off this trial and the impressive improvement in PAT-CR, pembrolizumab in combination with chemotherapy is now approved in the neoadjuvant and adjuvant setting for patients with triple-negative breast cancer. There are many more ongoing trials investigating the use of immune checkpoint inhibitors as well as targeted therapies in the neoadjuvant and adjuvant setting, as I listed on this slide. And we actually have several of these trials, including I-SPY2, which is an adaptive phase 2 clinical trial utilizing serial studies to predict response by imaging and molecular analysis, and offering more personalized treatment strategies based off of the molecular analysis. There are also trials looking at pembrolizumab plus IORT in the neoadjuvant setting, and in the adjuvant setting, looking at adjuvant atezolizumab in patients that have residual disease in IMpassion 030, and SWOG 1418, which evaluated adjuvant pembrolizumab, again in the higher risk population with residual disease after neoadjuvant chemotherapy. Despite the completion of intensive and definitive therapy for early stage triple negative breast cancer, a lot of these patients unfortunately have a high risk of recurrence, upwards of about 50 to 60%. Research focused on prevention now of metastatic recurrence is urgently needed, and really identifying early stage triple negative breast cancer patients at high risk of relapse may actually allow for us to tailor adjuvant therapy to ultimately improve metastases-free survival. Circulating DNA is highly prognostic in early stage breast cancer and may actually offer a sensitive method to identify minimal residual disease or molecular relapse, defined as patients who have detectable DNA in the bloodstream, but no clinical or radiographic evidence of metastatic disease. In a particular study published not too long ago, detection of ctDNA via the Signatera assay at either a single post-surgical time point or with serial follow-up plasma samples predicted metastatic relapse with very high accuracy, with serial follow-up plasma collections offering the highest sensitivity to predict relapse, and showed actually a median lead time of approximately 8 to 12 months prior to clinical or radiographic progression. Under the mentorship of Dr. Kevin Klinsky and Dr. Aditya Bardia from MGH, we actually developed a phase 2 clinical trial of ctDNA monitoring in patients with high risk early stage triple negative breast cancer, and intervention with the antibody drug conjugate sacituzumab govitecan for 6 months in patients that have a molecular relapse. I will serve as translational PI for this trial, DETECT-01, and this trial has been SWOG triage approved. Our primary hypothesis is that ctDNA identifies molecular relapse before the disease becomes clinically or radiographically apparent. And by intervening with adjuvant sacituzumab govitecan, we may be able to prevent metastatic recurrence and ultimately, hopefully, improve overall survival. The hypothesis in the clinical trial design is really based on 3 primary assumptions: that patients with positive ctDNA have no radiographic evidence of disease at time of first ctDNA detection, that micrometastatic disease that survived adjuvant chemotherapy can still be effectively treated with additional adjuvant therapy with sacituzumab govitecan, and that the second line adjuvant therapy, sacituzumab govitecan, will eradicate micrometastatic disease and thereby improve our cure rates, not just delay clinical recurrence. This type of strategy has been successful in other histologies, including prostate cancer, where a change in adjuvant therapy with the addition of apalutamide for a rise in PSA, so biochemical recurrence without radiographic disease, actually improved metastases-free survival. And we'd like now to test this in triple negative breast cancer. Here is the treatment and schema for the trial. So patients eligible for the trial are those with stage 2 to 3 triple negative breast cancer or high-risk patients with residual disease if they had received neoadjuvant chemotherapy. Patients must have completed all of their surgery, radiation, and systemic therapy prior to enrollment in the trial and have no evidence, clinical or radiographic, metastatic disease prior to trial enrollment. Patients will then be enrolled to step 1, which is the ctDNA screening. We expect approximately 95 patients to be enrolled in that. Of those 95 patients, we expect approximately 35 patients will have positive ctDNA, and potentially about 5 of those may actually have radiographic evidence of disease and therefore will not continue on trial. For those patients that have positive ctDNA, but no clinical or radiographic evidence of metastatic recurrence, they will receive sacituzumab govitecan for 8 cycles or 6 months, and will continue with ctDNA monitoring every 3 months, as well as radiographic imaging with CT chest, abdomen, pelvis at baseline, 6 months, 12 months, 18 months, and 24 months. The primary endpoint for this trial will be ctDNA clearance at 6 months, with secondary endpoints looking at distance disease-free survival, recurrence-free survival, imaging positivity in ctDNA positive cases, and then also looking at ctDNA changes over the course of the trial, as well as the safety and tolerability of sacituzumab govitecan in this population that has already been heavily pretreated. In terms of the TM specimen collections, we'll be looking at the detection of ctDNA or minimal residual disease using the CLIA certified Signatera assay with specifics in this slide. I've already mentioned this, but the primary objective of the trial is really looking at the ctDNA clearance rate after 6 months of adjuvant sacituzumab govitecan in the treatment population, those that have minimal residual disease, with secondary endpoints looking at the ctDNA positivity rate in the entire screen population, the rate of asymptomatic clinically detectable metastatic disease at time of first positive ctDNA results, and then looking really at the safety, tolerability, and compliance with additional adjuvant sacituzumab for 6 months in this patient population. As mentioned, the trial is SWOG triage approved, and this slide actually reviews the statistical plan for the trial. We anticipate a ctDNA clearance of at least 33% of patients will be clinically meaningful, while 20% or lower will be the null hypothesis, and we won't move forward with the trial. A sample size of approximately 30 evaluable patients will then provide an 80% power with a 2-sided t-test at 0.05 significance level. I've also included some feasibility rules for planning a subsequent randomized phase 3 trial as listed in this slide. Preliminary data generated from this phase 2 clinical trial will then be used to support a randomized phase 3 clinical trial called DETECT-02. And here is a treatment schema again. In this trial, patients with positive ctDNA, but again, with no evidence of clinical radiographic disease, will be randomized to receive standard of care monitoring per NCCN guidelines versus sacituzumab govitecan for 6 months in the adjuvant setting. The primary endpoint for this study is overall survival. In conclusion, triple-negative breast cancer is a molecularly complex disease with tumor heterogeneity and clonal evolution that makes it particularly difficult to treat. Immune checkpoint inhibitors, first approved for treatment of immune checkpoint inhibitors, are now approved for the treatment of metastatic triple-negative breast cancer and approved now with Pembrolizumab in the early stage setting. Biomarkers to predict the response to immune checkpoint blockade are urgently needed to ensure that patients are appropriately selected who would benefit from immunotherapy and avoid potential toxicities, particularly in those with early stage triple-negative breast cancer. Antibody drug conjugates targeting a variety of receptors offer a promising new strategy for the treatment of breast cancer, including sacituzumab govitecan, as mentioned. And we now need a more sensitive method of predicting early relapse prior to clinical or radiographic disease. This might actually present an opportunity with the ctDNA monitoring for early intervention to prevent or delay metastatic recurrence. Lastly, I'll end with a smaller project that I'm working on to improve diversity of patient enrollment in breast cancer immunotherapy clinical trials. Patient enrollment in clinical trials is really key to advances in our field, and increasing diversity in clinical trials is crucial to investigate the efficacy and safety of these novel immunotherapy and targeted agents in really a real world population. To this end, I've secured 2 V Foundation grants to help foster diversity in clinical trial enrollment, specifically clinical trials of immunotherapy and targeted therapies in breast cancer. As part of these efforts, I've collaborated with Dr. Rebecca Pence, the Ethics Fellows, and Dr. Greg Orloff to create 2 educational videos and a pamphlet on the immune system and immunotherapy to improve patient understanding of immunotherapy and hopefully improve their enrollment onto these trials. These educational tools will be used along with a social media campaign highlighting our investigator-initiated and industry-sponsored trials in breast cancer at Winship. With that, I'd like to end my presentation and thank all of my mentors and my team here at Emory. My Emory mentors include Dr. Kalinsky, Dr. Torres, and Dr. Harvey, along with collaborators for my projects, Dr. Pence, Dr. Orloff, Dr. Dodapkar, Kavita, and Dr. Madhav Dodapkar. The breast cancer and phase 1 working groups, our Winship leadership, my SWOG mentors, and lastly, my patients and colleagues. Thank you.
Great, thanks, Manali. It's a fantastic talk. Certainly, you know, pretty broad ranging and very helpful in us understanding more about what's going on. Real quickly for everybody, if you have questions, use the Q&A, which some of you have already. Just as a reminder, next week we'll have Dr. Narjust Duma from Harvard, who will present Beyond Salary, Gender Equity and Balance in Medicine. So let's get into the questions, Manali. The first came from Dr. Lawson. Should we start calling triple negative breast cancer that is also PD-L1 negative quadruple negative, and think about how we might categorize patients even more with breast cancer than we do currently?
Yeah, I mean, I think that's a really good point. Right now, PD-L1 expression is really the only marker we have to predict response to immunotherapy. And so you're right, when we think about patients with breast cancer, we're thinking about their receptor expression, but also PD-L1 status for sure.
Fair enough. Dr. Kalinsky has a couple of questions. Excellent job. If you use Pembrolizumab in the operable setting, what is its role in metastatic disease?
I think it's really going to be dependent on the time of recurrence or relapse from completion of Pembrolizumab. I mean, I think that's a really important and critical question that we still have to answer. And it might involve, again, novel techniques of resensitizing the immune response if patients had received immunotherapy in the operable early stage setting.
Is there any understanding or concern that there would be a change in PD-L1 status, or the kinetics of T-cell response might change over time?
Because of the fact that immunotherapy is so new to breast cancer, I think these are questions that are being investigated, but we don't know as of now. I think
okay. Another question from Dr. Kalinsky. If patient achieves a pathologic CR to neoadjuvant pembrolizumab with chemotherapy, is there a need to continue the adjuvant pembrolizumab?
Per the trial, those patients did continue with adjuvant pembrolizumab for 9 cycles. So as of now, our current standard of care is to still offer them adjuvant pembrolizumab. But I do think that this is an area that requires investigation, especially as we get long-term data on the toxicities of immunotherapy in the early stage setting in patients who are otherwise cured.
Yeah, I think it's a, you think about that point, when do you see your deepest response? And if you have a pathologic CR, obviously you've reached your deepest response at the point.
Yeah, there is some data in other histologies that suggests that the immune response to immune checkpoint blockade is actually higher with lower tumor burden.
Uh-huh.
So,
is there any notion, when you think about surgery as an immunologic event, perhaps where you're stimulating immune cells of a variety of types and numbers at the point of surgery, is there any notion that changes outcomes around the point of surgery, or other alterations in adverse event profiles?
Not that we've seen. I mean, the adverse event profiles were actually, they showed fewer immune-related adverse events than I actually expected. Really, the most common in breast cancer trials were infusion reactions and endocrinopathies like hypothyroidism and adrenal insufficiency.
Mm-hmm. Any other questions? If folks have them, please enter them in the chat or Q&A. Also, quick question, Manali, in terms of cellular therapies, is there a burgeoning area of cell therapies within triple negative? Certainly there is in the HER2 positive space for breast cancer patients. Is there any movement in the triple negative world for targets or cell therapies?
Yeah, I think that's really an evolving area. We are more advanced in cellular therapies, like you mentioned, with HER2 therapies, but not so much yet in triple negative. There have been advances in other targeted therapies in triple negative, like AKT inhibitors, which I didn't really discuss at all, FGFR alpha inhibitor, folate receptor alpha, inhibitors, and so forth, but not so much in cellular therapy yet in triple negative.
Gotcha. All right. Don't see any other questions as of now. Again, I want to thank you for taking the time for the group this morning to give your thoughts on triple negative disease. We're certainly happy you're with us and happy to be in the breast and phase 1 programs. And if no other questions as of now, we'll thank everybody for their attendance. Remind you of, again, next week's grand rounds with Dr. Duma from Harvard. And if you want to see any of the other upcoming lectures, please visit the Grand Rounds page on the Winship website or the Winship calendar.
Great.
All right.
Thank you so much.
Thank you, Manali. Take care.
Yeah.